Welcome to ICU Fellowship Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil, and we're back with another episode of Three Vivas. So, first of all, Maddie, it's Easter season. Any plans for Easter weekend?
Yes, I'm not working and the weather's meant to be good. And I've got some friends in town from London. So catching up with them, maybe being outside without rain, eating chocolate, the usual kind of stuff.
Yeah, that's right. Looking forward to eating more chocolates. Yeah, so I guess this time we're doing three vivas. So let's start with the first one. 65-year-old male out of hospital cardiac arrest receiving 6 microgram per minute of adrenaline with blood pressure of 100 over 70 millimeters of mercury. He is anuric for the last 2 hours. His GCS is 6, temperature is 37.6 degrees Celsius. So what are the factors that would you take into consideration when you're managing this patient's temperature?
So this would involve consideration of patient and logistic factors. In terms of patient factors, it'd involve consideration of his suitability for targeted temperature management. So this would involve considering his neurological status. He's currently a GCX6, so he would be suitable. But if he were conscious and able to follow commands, then he might not require as intensive temperature control. It would also involve consideration of the circumstances surrounding his arrest, such as whether he had uncontrolled bleeding or whether it's a traumatic arrest, and his current clinical status, including his hemodynamic status. So he is on moderate vasopressor support. And then also thought about his comorbidities and his ongoing treatment aims, whether he's for ongoing full active management, which in a 65-year-old male would generally be the case. And then also thinking about the potential adverse effects of cooling and thinking about this in the context of his clinical presentation. So risk factors adverse effects include hemodynamic instability, such as arrhythmias, hypertension, and bradycardia. He can have mild coagulopathy as a result. There may be an increased risk of infection, although more recent trials haven't confirmed this. There's a risk of shivering, decreased gut motility, and decreased tubular resorption in the kidney, which can cause diuresis and electrolyte derangement. And then it would involve a consideration of logistic factors. So this is mainly about institutional factors, what is a practice in the unit that I'd currently be working in and what staffing is available, and consideration of what temperature control devices are available, both to measure and to control the temperature.
Thanks, Maddie. So I guess the targeted temperature management after out-of-hospital cardiac arrest is a very important topic from the fellowship point of view. Is often asked either in the written format or in Viva, or also comes all the time during the discussion during the clinical exams. So often the favorite question from examiners is, what temperature would you aim for and how would you achieve this?
So I would aim for a normothermia in this gentleman, so maintaining a temperature less than 37.8 degrees. And I'd achieve this by measuring the core temperature, so ideally using a bladder temperature probe and having this coupled with a feedback-controlled surface cooling system. In the unit I currently work at, this is the blanket, and which then has a feedback control mechanism with a bladder temperature probe, and the core temperature and ideal temperature can be set, and then the cooling will be adjusted depending on the patient's core temperature.
Yeah, that's correct. So this 37.8 degrees Celsius target is again, it's a bit variable at the moment within Australia and New Zealand Intensive Care Society. And I guess all candidates can have kind of probably different answers to this question based on which units they practice and what targets are followed in their respective units, because normothermia again can mean differently to different individuals and different units. So I guess what is the rationale behind the targeted temperature management?
So the exact mechanisms by which targeted temperature management may be beneficial have not been fully elucidated, but the potential reasons why it could be beneficial include just avoiding fevers, which might decrease overall metabolic demand and neuronal injury, and it might decrease ischemic reperfusion injury. And this could be through multiple mechanisms, including decreased iron pump dysfunction, which decreases the influx of calcium into cells and neuroexcitotoxicity, decreased cell membrane leakage and edema, decreased production of free radicals and toxic metabolites, decreased overall metabolic demand and oxygen consumption, and decreased release of excitatory neurotransmitters such as glutamate and aspartate, as well as a decreased inflammatory response. It also could cause decreased cerebral edema because of decreased permeability of the blood-brain barrier and decreased vascular permeability. And it's also thought to have an intrinsic anticonvulsant effect. But a lot of this is basically studied in animal models or in significant cooling and hypothermia populations.
Yeah, that's right. And I guess the next very important question is, what is the evidence for targeted temperature management in patients with out-of-hospital cardiac arrest?
So the most recent evidence is pretty recent. It's from TTM2, which suggests that targeting hypothermia does not result in improved outcomes compared to targeting normothermia after out-of-hospital cardiac arrest. So just in more detail, this was a trial published in New England Journal of Medicine last year. It was multi-center, international and randomized trial of 1,900 adults with out-of-hospital cardiac arrest of a presumed cardiac or unknown cause who had sustained return of spontaneous circulation and remained unconscious. And this was classified as a 4-score motor response of less than 4 and not able to obey verbal commands. So the intervention group was a targeted temperature of 33 degrees for 28 hours, followed by controlled rewarming, which was compared to the control group, which was a targeted normothermia group who had a targeted temperature of 37.5 degrees and had early treatment of fever if the temperature was 37.8 or more. And they found that there was no difference in all-cause mortality at 6 months or any of the secondary outcomes, including functional outcome, health-related quality of life, and no difference in adverse events except for a higher rate of arrhythmia with hemodynamic instability in the hypothermia group. And this study supported the findings from the previous TTM trial published in 2013, which showed that there was no difference in mortality or neurological outcomes for patients treated with hypothermia to 33 degrees compared to 36 degrees after out-of-hospital cardiac arrest of presumed cardiac cause. Obviously, the in-hospital cardiac arrest population hasn't been robustly studied, and there were a lot of populations excluded within these trials, including the pregnant women. So it can be hard to generalize, but a lot of the evidence, the most recent evidence seems to suggest that normothermia is preferable now.
Yeah, that's correct. I guess TTM, both 1 and 2, they were quite landmark and practice-changing trials in many parts of the world. It is quite interesting to look at the literature around this topic, because a very landmark paper published by ANZIC CTG after the TTM trial was finished, that how it changed the practice and people become quite relaxed about the temperature targets. Patients started becoming more hyperthermic. So I guess to highlight the point that first 72 hours, the targeted temperature management is still the key, and we shouldn't just let patients be normothermic, because over the period of time they become hyperthermic. So monitoring the temperature and keeping the temperature within the targeted less than 37.5 is the key. Now there is a TTM3 trial will be coming up soon, which will probably compare the normothermia and no temperature management at all, whether there is a difference or not. And that will probably give us more idea about the outcomes in this cohort of patients when there is no temperature management at all. The LCOR guidelines have still stayed with target range of 32 to 36 degrees Celsius and likely to be updated after this TTM2 trial results. So watch out that space. So at the moment, less than 37.5 for at least 72 hours and avoid hyperthermia is the way to go for patients with out-of-hospital cardiac arrest. So let's move on to the second scenario. 34-year-old female who has presented with malaise and confusion. She got a background history of morbid obesity, and she has underwent bariatric surgery 6 months ago with extensive weight loss. Now she has been intubated for lowered conscious state in emergency department. On clinical examination, she looks quite dehydrated. She's afebrile. The blood pressure is 120 over 80 millimeters of mercury. Heart rate is 118 per minute. Stats are 99% on FiO2 of 40%. And prior to intubation, she was noted to have bilateral nystagmus. So what are your differential diagnoses here, and how will you approach this patient?
So there are multiple potential causes for this scenario, but my primary differential would be Wernicke'S encephalopathy, given the history of weight loss, altered level of consciousness, and nystagmus. But other potential causes include other causes of a decreased conscious state, including vascular causes such as vertebrobasilar ischemia or cerebellar hemorrhage, which might cause nystagmus. Malignancies, especially those involving the third ventricle or metastatic cancers or lymphoma. Infections, which could be CNS infections, such as herpes encephalitis or HIV encephalitis, a viral cerebellitis, such as CMV or EBV, malaria, TB, or a cerebellar abscess, or fungal meningoencephalitis. Drug-induced causes could include alcohol intoxication, polypharmacy overdose, other medications such as phenytoin, barbiturates, lithium, benzos, or amitriptyline withdrawal. And metabolic causes such as electrolyte disturbances, especially hypomagnesemia, hepatic encephalopathy, endocrine disturbances such as hypothyroidism, although this would be unusual with a tachycardia, hypoglycemia, other vitamin deficiencies such as B12 or vitamin E deficiency, or autoimmune causes such as cerebral vasculitis, any cause of seizures, normal pressure hydrocephalus, multiple sclerosis, or acute disseminated encephalomyelitis. So in order to further assess this patient, this would involve consideration of the history, exam, and investigations. For history, this would particularly involve obtaining some collateral history, maybe from a next of kin, including the timing and onset of her symptoms, such as the confusion and malaise, the extent of her weight loss and the diet that she's been on, and any other associated symptoms, such as infective symptoms or other neurological symptoms. Any comorbidities such as liver disease, endocrine disturbances, malignancy, medications, including other medications that can cause nystagmus, such as phenytoin, and any drug or alcohol use. A further exam would involve looking at her other vital signs, including her temperature, and a neurological exam within the scope of her being intubated, so including her cranial nerves, any signs of other nutritional deficiencies, or signs of infection, including CNS infection, such as meningism, and any signs of organ impairment, whether acute or chronic, such as signs of chronic liver disease. Investigations would be bedside, bloods, and imaging, and bedside would involve an ECG given the tachycardia, an ABG looking for her metabolic parameters and her gas exchange, a UA as part of a septic screen, and an echo because she might have signs of heart failure or dilated cardiomyopathy in the case of nutritional deficiencies. And blood tests would involve looking at her organ function and electrolytes, a red cell transcriptase for consideration of thiamine deficiency, although this isn't often important acutely as it takes a few days to come back, blood cultures and a beta HCG. And imaging would involve a chest x-ray. She's intubated and look for lines, a CT brain given her confusion, her decreased conscious state, and consideration of further imaging such as an MRI brain depending on the investigative findings. And then depending on the assessment, may consider things like an LP if there's a strong suspicion of a meningoencephalitis or an autoimmune vasculitis, and an EEG if there's a suspicion of seizures or non-convulsive status.
Great. And what are your management priorities in this patient?
I think the main thing is to identify the cause and the complications of her deterioration and presentation, and then the specific treatment will depend on the same. And then supportive treatment will involve obviously an ICU admission, full monitoring and access, and then organ support, so lung protective ventilation, neuroprotective care, and more specifically nutritional optimization given her significant weight loss history and her dehydration. So judicious fluid management, NG feeds and monitor for refeeding syndrome, dietitian input and control of her BSLs, and then consideration of other ICU supportive care such as DVT prophylaxis and supporting her next of kin.
Yeah, that's right. And I guess you mentioned about the Wernicke'S encephalopathy as one of the differentials. What is the pathophysiology of Wernicke'S?
So Wernicke'S is due to a significant deficiency of thiamine, and thiamine is a cofactor for key enzymes which are important in energy metabolism, including transcriptase and pyruvate dehydrogenase. And thiamine requirements depend on the metabolic rate. So there's an increased demand during periods of high metabolic demand and high glucose intake. Any deficiency in thiamine means that metabolically active tissue is unable to synthesize ATP, which can result in injury. And thiamine is also important for cerebral energy utilization. So any deficiency causes neuronal injury by inhibiting metabolism, and this may cause breakdown of the blood-brain barrier, NMDA excitotoxicity, and increased reactive oxygen species. The other thing with thiamine, it has limited storage in the body, and so there's about 30 milligrams, which stores last about 1 month. So people are prone to thiamine deficiency in certain situations.
Great. Now, what are the risk factors and clinical features of Wernicke'S?
So the risk factors mainly stem from decreased intake, decreased absorption, increased depletion, or any catabolic states, as there will be increased demand for thiamine. So things that can cause decreased intake include malnutrition, liver disease, alcohol intake, anorexia, or hyperemesis gravidarum. Things that can cause decreased absorption include alcohol again and any GI disease such as inflammatory disease or surgery such as bariatric surgery. Things that can cause increased depletion include diuretic diarrhea, dialysis and liver disease. And catabolic states include things like sepsis, pregnancy, hypothyroidism or things like metastatic malignancy. In terms of the clinical features, there's a classic triad, which is encephalopathy, ocular motor dysfunction, and gait ataxia. So encephalopathy is usually characterized by disorientation and inattentiveness, and in some cases there may be impaired memory or lethargy. Ocular dysfunction is classically horizontal nystagmus, but there also might be disorders of conjugate gaze with conjugate gaze palsies, lateral rectus palsy, or there can be anisocoria. And gait ataxia is usually kind of like a cerebellar gait with a broad-based stance. Other signs include things like hypotension, hypothermia, peripheral neuropathy, raised lactate, can get beriberi in severe cases, delirium, tachycardia, exertional dyspnea, and elevated cardiac output.
Thanks, Maddie. Can you now briefly outline the diagnosis and treatment for this lady?
So the diagnosis is mainly on clinical criteria. So it's 2 out of 4 criteria called the Crane criteria, which is a 2 out of 4 of dietary deficiency, oculomotor abnormalities, cerebellar dysfunction, or altered mental state or mild memory impairment. You can measure the red cell transketolase measurement, but the blood level may not reflect the brain thiamine level, so it also might be inaccurate. And the exclusion of other causes, such as looking at the assessment that we talked about earlier. Specific treatment is high-dose IV thiamine. There's different doses recommended between 300 to 500 milligrams TDS for 3 days, and then decrease the dose. And glucose, as thiamine is a cofactor for Krebs cycle, and then replacing magnesium, phosphate, and potassium, which especially the magnesium is a cofactor for thiamine.
Yeah, that's great. Usually we don't see Wernicke's that often, but I guess having that high suspicion is very important. And don't give glucose before thiamine. That's another important consideration.
Yeah, I think that's it's mainly in like longer term use, because looking into it, it says there's been no case reports of it if it's just a bolus glucose dose when they're hypoglycemic. It's mainly if it's like prolonged and you're giving glucose without thiamine.
Yeah, that's correct. So what I meant by that, yes, you're right. So obviously the patient is hypoglycemic and unconscious or in seizures. You need to treat hypoglycemia first. But when you start feeding without replacing thiamine, that's where the problem starts. So I think that's the kind of key consideration.
Yeah.
Now, let's move on to the third and final scenario for today's episode. A 64-year-old male who had an emergency AAA repair last night. His sedation has been ceased in anticipation of extubation, but nurses are concerned that he appears to be in a lot of pain. He got a background history of ischemic heart disease, type 2 diabetes, chronic back pain, for which he has been on long-term opioid treatment. So can you please outline how would you approach this situation?
So I think my concerns in this situation are about the cause of his pain. So it could be either due to a complication of the AAA, a new event, acute pain secondary to the surgery, or an exacerbation of his chronic pain. So my assessment would involve a targeted history exam and investigations to try and to delineate the cause of this. So in terms of the history, important aspects that I'd like to know about were the pain control leading up to his surgery. So the amount of opioids he was on prior for his chronic back pain, his level of function, and whether there was a neuropathic element, and his pain after the surgery. So what he's been on in terms of sedation and analgesia post-op this emergency AAA repair. It'd be difficult to get a clear history from him as he's intubated, but trying to see if he can point to where his pain is and try and localize whether it is in his back or somewhere around the surgical sites. I'd also like to know about, given he's got ischemic heart disease, the severity of it, whether he had previous surgery or PCI, his recent echo and ECGs, and the extent of his type 2 diabetes, whether there's renal involvement as NSAIDs might be contraindicated, and also then about the AAA itself. So the surgical and anaesthetic details, including any complications, whether he had any blocks or local anaesthetic infiltrated, and that his trajectory in ICU, especially in terms of his amount of analgesia and his vital signs. In terms of the examination, I'd look at his vital signs and his stability, looking especially for signs of hemodynamic compromise, his neurological function, and again, where he's identifying the pain as, and in terms of further examination, looking at for new signs of heart failure, new murmurs, and any signs of complications from his surgery. So looking at his abdomen, any signs of peritonism or his neurovascular status peripherally. And then in terms of investigation, it would mainly be to exclude any acute pathology. So bedside tests would involve an ECG to look for ischemic changes, an ABG to look at the lactate and metabolic parameters, and an echo to look at any wall motion abnormalities, especially given his history of ischemic heart disease. Bloods would be looking at his organ function, including creatinine and his LFTs, looking for signs of bleeding with a full blood count, coags, looking for ischemic heart disease complications such as troponin, and consideration of a group and hold and rotum, depending if there was a big concern about bleeding. And then imaging would depend on the findings initially, but potentially a CTA if there was concerns about ongoing complications from a leak after the AAA repair.
Great. And how would you manage this patient?
This would really depend on the findings of the assessment. So if there was a cause found that's an acute cause or a complication, it would be treating the complications or the acute cause, which would depend on the findings. But then supportive management, if this was mainly thought to be an exacerbation of his chronic pain, or if it was treating his pain to begin with, would involve multimodal analgesia, so regular paracetamol, also calculating the normal dose of opiates he's on and giving the same dose and adding extra for his acute pain. Consideration of neuropathic agents if there is a neuropathic component. And I think in this context, it's unlikely NSAIDs will be suitable given his age and his comorbidities. The other thing that would be important was to ensure that his pain was well controlled prior to extubation, as he's unlikely otherwise to be able to, take good deep breaths in and things like that after extubation.
Yeah, I guess managing the pain in ICU can sometimes be very challenging. And I guess every medication has got its own side effects. So understanding those side effects and then coming up with the appropriate strategies is really the key. Now, Maddie, that's the end of our 3 Vivas. I guess you got that kind of smile on your face, which kind of highlights that I'm going to be in another trouble. So do you have a joke for us?
Yeah, it's kind of Easter themed. I don't know. I've kind of struggled this week, so apologies. But I do have one. I'm not that thrilled with it, but yeah.
Yeah, sure. Go for it. I think.
Okay. Why can't you tease egg whites?
Oh my gosh. Because it's ugly. No.
No. Because they can't take a yolk. It's pretty bad.
Oh my God. Thanks, Maddie. I should just give up and then stop even answering these questions. It's just getting worse and worse for me. Having said that, I guess people who are taking break, wish you a very happy Easter and enjoy your time with family and friends.
Yeah, thanks for listening. See you next time.